Good afternoon, my dear students. Department of Outpatient Cerebral General Practice, Pronevich A.V, and today's my topic is cardiac arrhythmias and heart failure. A cardiac arrhythmias is a defined disturbance of the electrical rhythm of the heart. Cardiac arrhythmias are often a manifestation of structural heart disease, but may also occur causes of abnormal condition of defibrillation in an otherwise healthy heart. Paroxysmal tachycardia is a violation of the heart rhythm in the form of a sudden onset and sudden ending of the attack of heartbeats within a frequency of 140 to 20 per minute, while maintaining a regular rhythm. Supraventricular tachycardia. In terms of supraventricular tachycardia, this term is the occurrence of the group of the regular tachycardias that have a similar appearance on ECG. These are used neurocomplex tachycardias and are reduced by every entry frequency of automatic focus involving the atrium. The three principal types are atrioventricular nodal reentral tachycardia, atrioventricular reentral tachycardia, and atrial tachycardia. The term supraventricular tachycardia is technically incorrect in the main causes. The ventricles also form part of the re-entry circuit. Supraventricular tachycardia's rate is 180 per minute and the cure is complex and normal. Treatment of supraventricular tachycardia. Buccal tests. Verapamil intravenously slowly or metoprolol intravenously. If necessary, repeat the dose at 5 minutes interval, or it can give orally. Procainamide intravenously, drip for 10 minutes with the treat of decreasing blood pressure in combination with mezotone intravenously. Propofenol can be intravenously using over to 10-20 minutes necessary to repeat the dose. Or you can use propofenol in tablets, dose 150 to 300 mg once if necessary, again after 1-2 hours. In the testicular structure pathology of the heart, if necessary, you can add beta blockers, metoprolol, bisoprolol in tablets. Etidizine in tablets as necessary, again after 1-2 hours. In the absence of a structural pathology of the heart, if it's necessary, you can add beta blockers. In case of ineffectiveness, amiodarone intravenously, drip for 20 minutes, dose 300 mg, or it can be electropulse therapy. Prevention of attack of supraventricular tachycardia. Metoprolol in the tablets, bisoprolol in the tablets, betaxolol, sotalol, and the control of QR no more than 500 milliseconds, with an increase of no more than 25% of the original. Propofenol inside the absence of structural pathology of the heart. Etidizine or verapamil. What does mean structural pathology of the heart? It's mean past myocardial infarction, angina pectoris, left ventricular myocardial hypertrophy more than 14 mm, the presence of left ventricular dilatation, and the decrease of ejection fraction less than 40%. Ventricular tachycardia. Ventricular tachycardia occurs most commonly in the settings of acute myocardial infarction, chronic coronary artery disease, and cardiomyopathy. It is associated with intensive ventricular disease, bad left ventricular function, and ventricular aneurysm. In these symptoms, ventricular tachycardia may cause hemodynamic compromise or determinate interventricular fibrillation. Ventricular tachycardia is caused by abnormal automatically or trickle activity in ischemic tissue, or by re-entry within scared ventricular tissue. Patient may complain of palpitation of sinus or low cardiac output, including dyspnea, lightheadedness, and syncope. Ventricular tachycardia on ECG. You can see broad abnormal QRS complex rate more than 120 per minute. Treatment of ventricular tachycardia. In the presence of ventricular tachycardia with impaired hemodynamics, it means it's acute heart failure, blood pressure less than systolic 90, diastolic 60. You should use electropulse therapy. Treatment of monomorphic ventricular tachycardia with preserved ejection fraction. procainamide intravenously, or it can be lidocaine. Weight, you should check the weight is 1 milligram per kilogram intravenously by slowly bolus, or you can repeat it after 3-5 minutes to the dose 3 milligram per kilogram. Propofenone intravenously, amiodarone intravenously, the dose 300 mg, 5 milligram per kilogram over 15-20 minutes, or in case of ineffectivenessly, electropulse therapy. Sustained monomorphic ventricular tachycardia with reduced ejection fraction. First choice is amiodarone 300 mg, slowly over 50-20 minutes, and intravenously rate up to 1 milligram at 6 hours. Or you can use lidocaine 1 gram per kilogram with slowly intravenously, or in case of ineffectivenessly, electropulse therapy. Monomorphic ventricular tachycardia with normal QT interval, infusion of beta blockers such as propranolol, metoprolol, or you can use lidocaine intravenously, or you can use procainamide or amiodarone intravenously. Is that effectiveness so in electropulse therapy? Monomorphic ventricular tachycardia with a prolonged QT interval. First choice is magnesium sulfate, 10 ml intravenously slowly. Drug of the choice for long QT syndrome, or lidocaine, or accelerated atrioventricular pacing, or infusion of beta blockers. Propranolol, metoprolol, of course with sodium chloride. Prevention of ventricular paroxysms. In case of myocardial infarction, giant factors, and congestive heart failure, giving preference to beta blockers and class 3 drugs, satalol, amiodarone, or class 4 drugs, procainamide, etazine, propofenone, should be prescribed with course in combination with beta blockers. If necessary, combination therapy with amiodarone and beta blockers should be carried out with caution under the periodical supervision of the physician. The specific combination in the safest of the presence of a pacemaker and an implantable cardioverter defibrillator. Defibrillation. A supraventricular tachyarrhythmia with underdonation atrial electrical activities and consequently effectiveness atrial contraction. Atrial fibrillation is the most common thing in cardiac arrhythmia. The prevalence rises with age, affecting 1% of those aged 6 to 64 years, increasing to 9% of those the patient over the 80 years old. It is associated with significant morbidity and two-fold increase in mortality. This is mainly because it is associated with underlying heart disease, but also because it is associated with systemic embolism and stroke. Common causes of atrial fibrillation: coronary artery disease, valvular heart disease, special rheumatic mitral valve disease, hypertension, sinoatrial disease, hyperthyroidism, alcohol, cardiomyopathy, congenital heart disease, chest infection, pulmonary embolism, pericardial disease, and idiopathic non-atrial fibrillation. There you can see the reasons of similar risk factors for accident of atrial fibrillation. That's a lot, and even COPD, prediabetes, of course, and liquid profile, alcohol consumption as all risk factors for atrial fibrillation. Electrographical changes of atrial fibrillation include irregular RR interval when atrial ventricular contraction is not impaired, absence of P waves, and irregular atrial activations. So you can see the two examples of atrial fibrillation. A picture is usually a fast ventricular rate from 120 to 160. And the B is the chronic atrial fibrillation. The ventricular rate may be much lower due to effects of medication and AV nodal fatigue. Clinical features. The typical presentation in with palpitation, breathlessness, and fatigue. In patients with poor ventricular function or valve disease, atrial fibrillation may be prescribed or great cardiac failure because of loss in atrial function and heart rate control. A fall in BP may cause lightheadedness and chest pain, may occur with underlying coronary artery diseases. In older patients, atrial fibrillation may be associated with a rapid ventricular rate and may be asymptomatic, only to be discovered as a result of routine examination or ECG. Asymptomatic atrial fibrillation may also present with systemic embolism and its major cause of stroke in the elderly. Clinical atrial fibrillation, symptomatic or asymptomatic atrial fibrillation, this is documented by surface ECG. The minimum duration of ECG tracing of atrial fibrillation required to establish the diagnosis of clinical atrial fibrillation is at least 30 seconds on standard ventilates. A standard ventilates ECG recording or a single lead ECG tracing of more than 30 seconds showing heart rate with no describable repeated P waves and irregular error intervals where atrial condition is not compared. As diagnosis of clinical atrial fibrillation. This diagnosis of subclinical or clinical atrial fibrillation with ECG and ECG recorder program showing atrial fibrillation. Classification of atrial fibrillation. It can be first diagnosed, is not diagnosed before, and irrespective of its duration or the presence of severity of atrial fibrillation-related symptoms. Paroxysmal. Atrial fibrillation terminates spontaneously and with duration with 7 days of onset. Persistent. Atrial fibrillation that is continuously staying below 7 days, including episodes terminated by cardioverter after 7 days. Long-standing persistent, causing atrial fibrillation of more than 20 months duration where they decided to adopt a rhythm control strategy. And permanent atrial fibrillation that is acted by the patient with the physician and no further attempts to restore maintained sinus rhythm will be undertaken. Patient management to underrated A.V. pathway. The simple atrial fibrillation beta K ABC pathway. A. Anticoagulation avoid stroke. B. Better symptoms management. C. Cardiovascular and comorbid optimization stabilize the care of atrial fibrillation patient across all heart case levels and among different facilities. Common stroke risk factors are simulated in the clinical risk factor based on score. CHA-D-VAS. When initiated antithrombotic therapy, potential risk for bleeding also needs to be assessed. Non-modifiable and partially modified bleeding risk are important drivers of bleeding events in synergy with modifiable factors. This is a score risk for risk factor dimension for prevention of stroke, and this include congestive heart failure, hypertension, age more than 75 or older, diabetes mellitus, stroke, vascular disease with stroke, previously stroke, cardiovascular disease, age from 75 to from 65 to 74, and sex category for male. And according to points words, maximum it can be 9. And then this is a clinical risk factors of score as regards bleeding and uncontrolled hypertension, abnormal renal or hepatic dysfunction, stroke, bleeding history, or predisposition of label urinary elderly drugs or excessive alcohol drinking. And according to the previous scores tables, so these tables that the patient with atrial fibrillation need for oral anticoagulant therapy. If your patient has a valvular defect, your patient can use only vitamin K antagonist, this warfarin. There is no prosthetic mechanism heart valve effect or moderate severe mitral stenosis, your patient, according to this score risk, should use or shouldn't use anticoagulant therapy. Yes, if your patient has score points in male 0 or in male 1, your patient no need antithrombotic therapy. But if your patient has more than for male 1 and for male 2, anticoagulant therapy should be considered, such as rivaroxaban, dabigatran, apixaban, or warfarin. B. Beta symptoms control, rate control, beta blockers, non-hydropyridine calcium channel blockers, diltiazem and verapamil, digoxin, or combination therapy. Some antiarrhythmic drugs also have rate-limiting repairs, almedrol, dronidarone, but generally they should be used only for rhythm control. The rhythm control strategy refers to attempts to restore and remain sinus rhythm, and major combination treatment approaches including cardioverter, antiarrhythmic medication, and catheter ablation. Among with an aberrant rate control, anticoagulant therapy, and competitive cardiovascular prophylactic therapy, upstream therapy including lifestyle and sleep apnea management. This is technique how should we restore the risk cardioversion for atrial fibrillation. If your patient is hemodynamically unstable, it should be emergency electrical cardioversion. If your patient is hemodynamically stable, check out anticoagulant status. If it is already used anticoagulant produced with cardioversion, decided immediately only for possible spontaneous cardioversion. If not already used anticoagulant therapy and the duration of this episode less than 48 hours, it can be early cardioversion. Early cardioversion can be pharmacological or it can be electrical cardioversion. What if it's this episode of duration more than 48 hours or known electrical cardioversion more than 48 hours of atrial fibrillation onset, pharmacological version should be used within 3 weeks of anticoagulant therapy and to prevent thrombosis, and after 3 weeks it can be only cardioversion because to prevent stroke. Antiarrhythmic drugs used for restoration of sinus rhythm. Amiodarone, initial dose for cardioversion 5-7 mg per kilogram or 1-2 hour. Propofenone, it can be oral use or intravenously used. Flecainide oral, or it can be intravenously. Vernicalate and butylate not available in some countries. Amiodarone is for use long-term maintenance of sinus rhythm in atrial fibrillation patients. It should be used orally 3 times per day, 200 mg daily or 4 weeks, then 1 tablet 200 mg daily. Propofenone orally 3 tablets 150 300 mg 3 times daily. Flecainide, sotalol, and dronidarone. This long-term rhythm control therapy, patient according to their condition and comorbid diseases. Known of minimal signs of structural heart disease, dronidarone, flecainide, propofenone, sotalol, and not effectiveness catheter ablation. Is a patient with cardiovascular diseases, significant valve diseases, the first choice are amiodarone, dronidarone, sotalol, not effectiveness catheter ablation, and a patient with heart failure with reduced ejection fraction, amiodarone. Heart failure. Heart failure is not a single pathological diagnosis, but a clinical syndrome considering cardinal symptoms, breathlessness, ankle swelling, and fatigue that may be accompanied by signs due to structural or functional abnormalities of the heart that results in elevated intracardiac pressure or great cardiac output at rest and duration exercise. Heart failure is due by myocardial dysfunction. It can be systolic, diastolic, or both. It's divided into according to left ventricular ejection fraction. It's three types. Reduced left ventricular ejection fraction is defined as less than 40, as the house with a significant reduction of left ventricular systolic function. This heart function with reduced ejection fraction. Patient with left ventricular ejection fraction between 41 to 49 have mildly reduced left ventricular systolic function. It's called heart failure with mildly reduced ejection fraction. And the third, this with normal left ventricular ejection fraction more than 50%, but the patient has functional cardiac abnormalities and raised natriuretic peptide. It's called heart function with preserved ejection fraction. Symptoms inside typical of heart failure. It can be typical and more specific. Symptoms typical: breathlessness, orthopnea, paroxysmal postnatral dyspnea, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise, ankle swelling. And signs more specific: elevated jugular venous pressure, irregular reflux, short heart tone, arrhythmia, that displaced a typical impulse. Symptoms less typical. It can be natural cough, wheezing, agitated feeling, loss of appetite, confusion, depression, patient, syncope, dizziness, and apnoea. And signs less specific: weight gain, weight loss, tissue wasting, cardiac murmur, pulmonary crepitation, peripheral edema, peripheral infusion, tachycardia, irregular pulse, tachypnea, chain stalk respiration, hepatomegaly, ascites, cold extremities, and oliguria. So the definition of heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection that we said before. According to New York Heart Association Function Classification, there are 4 classes of severity and physical activity. So, class 1, no limitation of physical activity. Ordinary physical activity does not cause due to breathlessness, fatigue, or palpitation. Class 2, light limitation of physical activity. Comfortable at rest, but ordinary physical activity results in undue breathlessness, fatigue, or palpitation. Class 3, main limitation of physical activity. Comfortable at rest, but less than ordinary activity results in undue restlessness, fatigue, or palpitation. Class 4, unable to carry on any physical activity without discomfort. Symptoms at rest can be present. If any physical activity is undertaken, discomfort increased. The diagnosis algorithm for chronic heart failure. So, suspected heart failure: risk factor, symptomatic, symptoms and signs, abnormal ECG, and you should check for natriuretic peptide. Is it more than 125 or diuretic natriuretic peptide more than 35? You should check echocardiogram, abnormal findings, and then heart failure diagnosis according to ejection fraction. It should divide into these 3 parts, and the diagnosis is considered establish the diagnosis of heart failure. Pharmacological treatments for patients with heart failure with reduced ejection fraction. There are 3 main goals of treatment for patients with reduced ejection fraction: reduced in mortality, prevention or recurrent hospitalization due to worsening heart failure, improvement of clinical status, functional capacity. Relation of 3 renin-angiotensin, aldosterone, and symptomatic nervous system with angiotensin converting enzyme inhibitor, ACE inhibitor, or an angiotensin receptor neprilysin inhibitors, beta blockers, and mineral corticoid receptors agonists. It can be shown to improve several, reduce the risk of heart failure hospitalization, and reduce symptoms in patients with heart failure with reduced ejection fraction. The sodium glucose corresponded to inhibitors, dapagliflozin and empagliflozin, Added to therapy with ACE inhibitor or ARIA beta blocker or metaconium receptor antagonist reduce the risk of cardiovascular death and worsen heart failure in patients with heart failure, reduce ejection fraction. Unless contraindicated is not tolerated, the dapagliflozin or empagliflozin are recommended for all patients with reduced ejection fraction already treated with an ACE inhibitors or arrhythmia beta blocker or an spironolactone rated or whether they have diabetes or not. This is a pharmacological treatment for patients with heart failure with reduced ejection fraction. You see all these groups that I said before, and according to ejection fraction and QRS complex wide. So is this less than 130 milliseconds and wherever appropriate, ECD. It means implantable cardioverter defibrillator without no effectiveness using the drugs. If the QRS complex more than 130 milliseconds, you can use implantable cardioverter defibrillator, and this is using cardiac resynchronization therapy with defibrillator or cardiac resynchronization therapy with pacemaker therapy. Other pharmacological treatment indicated in select patients with, according to new classification class from 2 to second to 4, heart failure with reduced ejection fraction. Angiotensin a type receptor blocker, ivabradine, this EF channel inhibitor, very Tigard, label guanylate cyclate receptor stimulator, hydrolysine and estrobidinitrate and digoxin. Recommendation for an implantable cardioverter defibrillator in patients with heart failure. Secondary and primary prevention. Secondary prevention. Cardioverter defibrillator is recommended to reduce the risk of sudden cardiac death in all cases, mortality in patients who have recovered from a ventricular arrhythmia causing hemodynamic instability and who are expected to survive more than 1 year with a good functional status. In the absence of reservoir causes, unless the ventricular arrhythmia has occurred less than 48 hours after myocardial infarction. And primary and cardioverter defibrillator is recommended to reduce the risk of sudden death in all causes, mortality in patients with symptomatic heart failure class 3 according to New York classification of the ischemic etiology, unless they have had myocardial infarction, and ejection fraction less than 35 despite more than 3 months of optimal medical therapy. Cardiac resynchronization therapy. Cardiac resynchronization therapy is recommended for symptomatic patients with heart failure in sinus rhythm. As I said, it's a duration more than QRS complex, more than 150 milliseconds, and left bundle bench block QRS morphology, and with left ventricular ejection fraction less than 35, despite normal medical therapy, in order to improve symptoms and reduce mortality and morbidity. Cardiac resynchronization therapy rather than right ventricular pacing is recommended for patients with heart failure with reduced ejection fraction, regardless of New York classification class or QRS within who have an indicated for ventricular pacing for higher degree antiventricular block in order to reduce morbidity. This includes patients with atrial fibrillation. Treatment of heart failure with mild reduced ejection fraction. The presence of elevated BNP more than 35 and pro-BNP more than 125, and other evidence of structural heart, such as increase of left atrium size, left ventricular hypertrophy, or anticardiographic measures, or left ventricular filling, were diagnosed more likely but are not mandatory for diagnosis if they centrally regarding the measurements of left ventricular ejection fraction. And the pharmacological treatment, these patient. For these patients, angiotensin chromatin enzyme inhibitors or angiotensin receptors 2 type receptor blockers, beta blockers, mineralocorticoid antagonist, angiotensin receptor neprilysin inhibitors, azodal-decoxynivabrudin, and devices severity may definite patient with left ventricular ejection fraction more than 35. The treatment of a heart patient with preserved ejection fraction. To date, no treatment has been shown to conveniently reduce mortality or morbidity in patients with heart failure with preserved ejection fraction. Thank you for your attention. See you in our classes.